Thank you very much for inviting me to the Shaukat Khanum Cancer Symposium. My name is Dr. Badaginai. I'm one of the respiratory physicians at the University Hospital of North Midlands in Stoke-on-Trent in UK. And I'm going to talk about malignant pleural effusion, recent evidence and current best practice. And the next 20 minutes, I'm going to talk about diagnosis, prognosis, treatment options, personalized patient-centered approach, some recent seminal practice-changing research, and the future directions in malignant pleural effusion. So malignant pleural effusion is quite a common pathology. We see up to 50,000 cases per year of malignant pleural effusion in UK, and this is increasing nowadays with the aging population. Up to 15% of cancer patients develop malignant pleural effusion, and the median survival is between 3 to 12 months for all cancers. Commonly, it's a lung cancer. More than 1/3 of the patients who develop malignant pleural effusion, followed by breast cancer, then hematological malignancy, then genitourinary and GI cancers. So how do you diagnose malignant pleural effusion in someone who's got alarm symptoms and you have a chest X-ray showing unilateral pleural effusion? Then you need a staging CT, and you need a portal venous phase CT scan, because if you're looking at the pleural thickening, then you will need this will show you the enhancing pleural thickening. The features of pleural malignancy on CT scan are mediastinal pleural thickening, as shown in here, pleural nodularity, then circumferential pleural thickening, and parietal pleural thickening of more than 1 centimeter. Once you've had the CT scan, then you need a thoracic ultrasound guided pleural aspiration. So for those of you who've not seen pleural or thoracic ultrasound before, this is the black is the fluid, this is the subcutaneous tissue, and this is the diaphragm. So thoracic ultrasound is quite a handy tool in our pleural clinics. So it can tell you the depth of the pleural effusion, the shape of the diaphragm. So you can see this is a large echogenic pleural effusion and the diaphragm is inverted. So this will also help you guide the patient severity of symptoms as well. As the diaphragm, inversion of diaphragm is a handy tool which will tell you about the severity of symptoms. It can also tell you about if there's any nodules. So you can see there are quite chunky diaphragmatic nodules suspicious of malignancy. It can easily be biopsied. It can also tell you about the depth of the pleural fluid. So you can see here it's about 5 centimeters before you reach the pleura. So you'll probably need a bigger needle to sample this pleural effusion. It can also tell you the nearby structure. So you can see here that there is left ventricle lying just about at 5-6 centimeters. If you're not careful or doing a blind procedure, you can easily puncture the left ventricle. This is the same patient. So on the CT, you can see this appears like a unilocular effusion. And when you do a thoracic ultrasound, this is a multi-septated, multiloculated effusion, which can be quite difficult to aspirate. So the thoracic ultrasound will help you guide your needle for a successful pleural tap. So once you've taken the pleural fluid and you send it for pleural fluid cytology for cancer typing. So this was an elegant study done by Nick Maskell's group in Bristol, which looked at pleural fluid sensitivity for different cancer types. And we can see ovarian cancer, lung adenocarcinoma, and breast cancer, they have a fairly high sensitivity, pleural fluid sensitivity, as opposed to non-adeno lung cancer and mesothelioma. So more than likely for these cancers, you will need some sort of pleural biopsy for diagnosis. So what about the sensitivity of pleural fluid, sensitivity of different pleural biopsy methods? We used to use closed pleural biopsy, which is more or less abandoned in UK. It has a very low sensitivity of less than 50%. Nowadays, we either use CT guided or ultrasound guided needle biopsy, which has a fairly high sensitivity of more than 80%. But the gold standard is thoracoscopy or wedge-guided pleural biopsy with a sensitivity of more than 95%. In UK these days, us pulmonary physicians, we do thoracoscopy as opposed to surgeons. So prognosis in malignant pleural effusion, in the last few years, we've had a couple of scores which have been developed. So the LENT score has been developed by the Nick Maskell's group in Bristol, which looks at pleural fluid LDH level, ECOG performance status, neutrophilic lymphocytic ratio in the pleural fluid, and tumor type. And based on these variables, the patients are divided into low risk, moderate risk, or high risk group. The low risk group has a median survival of up to a year, as opposed to high risk patients who have a median survival of a month and a half. So you can perhaps guide your management strategy based on this score. The PROMISE score has been developed by Naj Rahman's group in Oxford, which looks at the variables. So it has a clinical and a biological PROMISE score. So this looks at if the patients have had chemotherapy, radiotherapy, hemoglobin, white cell count, CRP, ECOG performance status, and cancer type. And the biological PROMISE score adds a biomarker, TIMP1, which is tissue inhibitor of metalloproteinases. And on the right hand side, we can see both the LENT score, biological and clinical and biological PROMISE score. They correlate very well with survival, more so with the PROMISE score. But the LENT score is quite easier to use and has lesser variables. So what about treatment considerations? So when I see a patient in my pleural clinic, so the questions I usually ask myself, do I have to treat this effusion? Is the patient symptomatic enough? What are the treatment options? Does the patient prefer inpatient care or outpatient care? What is the likely prognosis of the patient? That's where your LENT score or PROMISE score comes in. And which option is the best? And that's where the recent evidence comes in. So this is a nice flow chart from the recent American Thoracic Society clinical statement of malignant pleural effusion. When you have a patient with malignant pleural effusion, then you have to see whether is the patient symptomatic. If the patient is not symptomatic enough, then you can perhaps just watch and wait. If the patient is symptomatic, then you do a large volume therapeutic paracentesis, and then you look at the improvement in symptoms. If the symptoms improve, then you do their survival assessment by doing the prognostic scores. If their survival is poor, then you can perhaps opt for a palliative approach. If the survival is better in terms of months, then you look for lung expansion. If the lung does re-expand post-therapeutic aspiration, then you have option of indwelling fluid catheter or talc fluidosis via chest drain. If however, it's a non-expandable lung, then indwelling fluid catheter is the recommended option. Then you have different options, which we will discuss further. So treatment options. So it is, as I said initially, it is a patient-centered approach. So what the patient wants. Does the patient prefer an inpatient care or outpatient care? The inpatient care, you have chest drain with talc fluidosis, and outpatient care is indwelling fluid catheter. So if it's chest drain and the patient has to stay in for 3 to 5 days, indwelling fluid catheter is a day case procedure. Chest drain with talc fluidosis is not recommended for non-expandable lung. The IPC is the treatment of choice for a non-expandable lung. Fluidosis success rate for talc fluidosis with chest drain is more than 70%, and for IPC is more than 50%. Lesser risk of infection with chest drain and talc fluidosis, but IPC is a foreign body and has a high risk of infection. So these are all the things which we discuss with the patient when we see them in the pleural clinic and give them the option of deciding. So what is the latest evidence? So we've had lots of trials coming in the last 10 years or so. So we'll discuss these points one by one. So which option is best? Is it talc fluidosis or indwelling fluid catheter? So we've had Time 2 trial, which was published by Naj Rahman's group in 2012. So this looked at indwelling catheter and compared with talc produces by chest drain in relieving breathlessness. So they looked at visual analog score of breathlessness, so which is a score of 0 to 100. 0 is no breathlessness, and 100 is the worst imaginable breathlessness, and the patients were asked to score on this. And we can see there was no difference in relieving dyspnea in either talc-2-desis or indwelling fluid catheter. IPC, however, reduced hospital days and further pleural procedures. The EMPERL trial from Gary Lee's group in Perth looked at the same thing. So they compared IPC with talc-2-desis, but they looked at their outcome was different. So they looked at reducing time in hospital. So the IPC reduced further time in hospital to 10 days compared to 12 days, so slight reduction with IPC. But the patients who have had IPC, they have lesser procedures, so only 4 further procedures compared to 22 in patients who had talc-pleodesis. So which option is better? So is a large bore drain better? And what about non-steroidals for pleodesis? So the time 1 trial looked at small bore drain versus large bore drain and looked at pleodesis failure rate at 3 months. So we can see that 24 French chest drains, they have a better success rate compared to a smaller bore chest tube for a pleodesis. The non-steroidals and opioids had a similar pleodesis failure rate, and we should not avoid non-steroidals as opposed to the traditionally held belief of non-steroidals reducing inflammation and thus reducing pleodesis. So both non-steroidals and non-steroidals and opioids have the same success rate. So which option is better? So talc slurry is done traditionally via the chest drain, and talc poudrage is done via medical thoracoscopy. Is any better than other? So TAPS trial from Rahul Bhatnagar and Nick Maskell's group, they compared talc poudrage versus talc slurry and looked at the pleodesis success rate. No difference at 30 days, no difference at 1 month, and no difference at 6 months. So both talc slurry and talc poudrage are equally effective, and the talc has a success rate of up to or more than 70% at 6 months. So what about indwelling fluid catheter drainage frequency? So the ASAP and EMPERL-2 trial looked at that. So ASAP trial from Momin Wahidi in North Carolina looked at aggressive daily drainage and compared it with standard alternative drainage. Their primary outcome was autopleodesis rate at 12 weeks, and we can see significantly better, 47% compared to 24% in daily drainage arm. And time to autopleodesis was significantly better, less than 2 months compared to 3 months in standard care arm. EMPERL-2 trial from Gary Lee's group looked at daily versus symptom-guided drainage. Their primary outcome was shortness of breath over 2 months. No difference in shortness of breath in daily or symptomatic IPC drainage, but as similar to the ASAP trial, the autopleodesis rate was much better at 3 months, at 2 months and 3 months in the aggressive arm compared to symptom-guided drainage arm. So what about IPC combinations like IPC plus? So IPC plus trial and SWIFT trial looked at that. So IPC plus was a significant trial which looked at patients with IPC who had regular drainage and then had talc pleodesis if there was no if the lung expanded. The primary outcome was pleodesis success at 5 weeks, and we can see significantly better in patients who had talc pleodesis at 43% compared to 23% 5 weeks, and 51% and 27% in talc versus placebo. So IPC with talc increases your chances of talc pleodesis significantly. The SWIFT trial looked at silver nitrate coated IPC. Their primary outcome was fluorescein success compared to the traditional IPC. Unfortunately, a negative study and silver nitrate coated IPC led to reduced fluorescein compared to your traditional IPC. So, what about the timing of fluorescein? So, simple trial looked at thoracic ultrasound guided fluorescein. So, patients who have had chest drain with fluorescein, they had thoracic ultrasound done every day, and they looked at lung sliding. If there was lung sliding present, that meant that there was no fluorescein. If there was absent lung sliding, then that meant that the fluorescein was successful. And they compared it with the standard, which is drain removal if there is drainage of less than 250 mils. The primary outcome was length of stay, which was significantly better in the thoracic ultrasound arm, 2 days compared to 3 days in the standard arm. Fluorescein failure rate better in the thoracic ultrasound arm as well. And the thoracic ultrasound guided care was cost effective as well as it reduced hospital days. So in essence, the IPC evidence favors active regime. So you should be aiming for daily drainage because it increases your fluorescein success rate significantly. And you should be aiming for talc fluorescein, which again increases the chances of having a successful fluorescein quite significantly. What about trap lung? Trap lung is a bugbear of us pleural physicians. It's basically failure of pleural apposition more than 25%, and it occurs in 20 to 25% of the patients. It is associated with poor survival. It's one of the key factors in decision making in malignant pleural effusion. IPC is the treatment of choice. If it's more than 25% of trap lung, then you can opt for either IPC or talc fluorescein. If less than 25%, it can be quite difficult to predict if it's less than 25% or not. In the interest of time, I'll skip these studies, but Fabian Maldonado's group from Tennessee have looked at pleural manometry to see if we can predict non-expandable lung, but not successful. There is some evidence coming up that pleural elastins can be a marker of non-expandable lung, but still early days. So, summary of recent evidence. We have equivalent symptom control with IPC and talc fluorescein. IPCs, patients, they spend less time in hospital, they have lesser pleural procedures at the risk of infection. IPC should be managed actively with daily drainage or talc fluorescein. With inpatient fluorescein, there's no difference between talc slurry or Pudraj. There's no need to avoid non-steroidals. The pleural failure rate is slightly higher with small pore drains. Perhaps there will be a future of pleural elastins or manometry in predicting non-expandable lung. So last couple of slides. So what about pleural intervention and systemic anti-cancer therapy? There's no evidence to support use of systemic anti-cancer therapy to reduce the need for definitive pleural interventions. You don't need to defer pleural procedures until after systemic anti-cancer therapy, but you can perhaps opt for a watch and wait approach in chemoresponsive tumors like breast, ovary, prostate, small cell cancer, germ cell tumors, or hematological malignancy. We're often asked about IPCs, increasing the risk of infection in those receiving chemotherapy. No evidence of that, and there's been multiple studies done to look at that. So what about the future? There's quite a few trials which are ongoing. Optimum trial is comparing chest drain with talc fluorescein with IPC and talc fluorescein and looking at quality of life of these patients. Mesotrap is looking at mesothelioma patients with trap lung, comparing IPC with VATS pleurectomy. EMPL-3 trial comparing IPC with VATS fluorescein. TACTIC trial comparing thoracoscopy with talc and IPC and comparing thoracoscopy with talc and chest drain. ASAP-2 trial is comparing IPC with daily drainage and IPC with talc with daily drainage. And Stratify trial looking at small pleural effusion in otherwise radically treatable non-small cell lung cancer and looking at the prevalence of occult pleural mets. So quite a few interesting trials ongoing. So in conclusion, the management of malignant pleural effusion is quite complex. Informed patient choice is essential. We should be focusing on patient-reported outcome measures like breathlessness, quality of life, lesser days in hospitals, and fewer pleural procedures. Informed patient choice is essential, as I said, and we should ask patient whether they want an inpatient care or outpatient care. We should have a better understanding of non-expandable lung, hopefully in the future, and we should hopefully have better prognostic markers and biomarkers available in the future. Thank you very much, and I'll be happy to take any questions. Hopefully, I'll be able to attend the Q&A.
I'm really excited to talk with everybody because this is one of the most exciting times in the treatment of cancer that there's ever been. And I'm a medical oncologist, and now I've been involved with Circular Gene, which is a liquid biopsy company based in Birmingham for the past 3 years. And I do think Circular Gene is the best liquid biopsy company, and patients deserve the best. But tonight we'll focus on just an educational focus on the power of liquid biopsies to improve cancer treatment. Everybody has had family, loved ones, friends with cancer. And everybody that's diagnosed with cancer, death hits between the eyes and in their hearts. And now we have the capability to better identify what a best treatment is for that individual, not just being left with putting a patient in a group and okay, you have a lung cancer, so we're going to treat the lung cancer. Now we have the technology to understand what's driving that lung cancer, and more treatments can now target what is driving that lung cancer. Now, I was an intern back in 1979, and back in 1979, when I was an intern, MRIs did not exist. It was a CAT scan because there was only axial views, and those were just coming about, not in every hospital or in every location. We had rudimentary nuclear scans, did not have PET scans. And the treatments were pretty much industrial strength chemotherapy that had a lot of toxicity in certain cancers, such as testicular cancer, tremendous curative outcomes. Of other cancers, only a small benefit of extending life, and certainly potentially robbing quality of life. And then things sort of slowly begin to change. It was in 2004. That's when the first targeted therapy of EGFR in lung cancer came about. And then in 2015, immune therapy came about. But up until the liquid biopsies, all of the imaging, the CAT scans, the MRIs, the PET scans, it could see the cancer. It could tell you where it was, but it could not tell you what caused the cancer. So it really could not guide individual treatment. But with new technology of being able to look at fragments of the ctDNA and RNA, then you could really provide good treatment. Now, one thing to notice, this really became mainstream at the American Society of Clinical Oncology annual meeting in 2016. So the whole liquid biopsy understanding is still evolving. It has to have It has to be a lot of steps of understanding, because what we thought we knew about some things turned out not to be known. And it's something that the clinical utility is rapidly evolving in metastatic cancers and even in earlier cancers across all cancers. I just want to quickly digress and just talk about immune therapy. This was an individual, and other than some of the bladder, the kidney, the left kidney, all the other dark spots are cancer. Now, this individual had a metastatic melanoma. And with immune therapy, from August to January, this is the dramatic response. You can see how much lymphedema, how much congestion there was in the leg, such that she couldn't get her pants on. Then you can see the dramatic improvement. Now, this individual's 94 years old, loved to bake pies and pull weeds in her garden. And I don't bake pies and I don't like to pull weeds, but getting her back to do that gave her tremendous quality of life. And how did that happen? It was just a medicine given IV that would, the cancer will develop a block such that a person's own immune system can't see it. Now we can give immune therapy, immune checkpoint inhibitors that can undo that block, such that her own immune system that allowed this cancer to develop, now her own immune system was treating the cancer. So immune therapy is just one of the biggest advances there's ever been in the treatment of cancer, as is targeted therapy. But now with liquid biopsies, we're even able to see more, see better, and patients get better treatment. What is a liquid biopsy? That's caused a lot of confusion to medical oncologists. Everybody initially thought, oh, a liquid biopsy is going to be a blood test that will diagnose the cancer. No, you really need to have a tissue diagnosis to know with 100% certainty that it is a cancer. It had been known for a decade, 15 years, that you could identify circulating tumor cells in the blood. But the problem with that, most of those cells were non-viable, which really did not reflect anything. But a liquid biopsy is looking at the circulating tumor DNA, fragments of the DNA, and the DNA is sort of controls cellular function and can causes the cancer, and then that altered DNA controls the cancer, and then RNA is the messenger. So it's fragments of circulating tumor DNA and RNA identified in the plasma from a simple blood test. This is just where things are in 2022 in the treatment of non-small cell lung cancer. They have 1, 2, 3, 4, 5, 6, 7, 8, 10 different potential targets. It's impossible to order individual tests to get these needed mutations and fusions on what can best treat that particular cancer. But you can, with next generation sequencing, you can construct the panel and get everything you need. You can expand the panel as the advances keep going, and everything's still obtained just from the simple blood test. And as you can see, just the number of therapies for each target, 5, EGFR, ALK, and more, this is becoming the majority in lung cancers. And I wanted to show that just to get a perspective because of the improvement that liquid biopsies are achieving. This is in metastatic lung cancer. For the patients who had a targeted therapy, they had one of those 10 targets and they got the proper treatment. The median overall survival, that 50th person out of 100, the median overall survival was 40 months. But even at the 5-year mark, 40%, 40 out of 100 were still alive. If they had the potential target, and if it was either not tested for or not treated, the median overall survival was 20 months. In the past, we would get excited about a 2 to 3 month improvement in median overall survivals. But with targeted therapies, you can double that, and that's 2 extra years. And some patients, 40 out of 100 are still alive at the 5-year mark. So it's imperative that you know that there's a target that you can target, because those patients do much better with that targeted therapy that is targeting what's driving the cancer and shutting off the cancer, as opposed to the standard chemotherapy, which does nothing but kill some of the cancer. Then it becomes, who needs a liquid biopsy? And this is where any new technology will cause new knowledge that was not known before. And believe me, new knowledge can be very unsettling to a lot of doctors and even oncologists. And we're dealing with new knowledge all the time. But who needs a liquid biopsy? In my opinion, anybody with cancer does, because you do not know what you're going to find that can make a huge difference in their life. You don't know. You need to make sure there are not certain things such that your standard treatment's going to do harm. And you don't know the full stage of a cancer. And if there's circulating tumor DNA identified in the blood test, you know there are some circulating cancer cells that could land and metastasize. So even in stage 1 cancers, and that's why it's so important, anybody with cancer. But what's really some unique findings, the liquid biopsy will identify more mutations in tissue. It can be very prognostic of outcomes, no matter what the stage. It can overcome the tumor heterogeneity. It will predict treatment benefit, and you can monitor response, and you can identify the micrometastatic disease. That's what needs to be targeted, not something that's not metastasizing, but the cells and the clones that are. This was just an example of patients with metastatic lung cancer. They had both tissue next generation sequencing, molecular profiling, and they had plasma next generation sequencing with the liquid biopsy. This 100% out here is when they combine both findings. But then there's a sequence of doing tissue first. It missed 1/3 of the mutations. If plasma was done first, it identified 87% of the mutations. Ideally, both should be done. There can be a problem with limited biopsy samples in a variety of cancers that making tissue difficult for full molecular profiling. And a lot of oncologists will still adhere to the old teaching that tissue is the gold standard. We'll only do plasma if tissue doesn't find something. Well, tissue, something cannot be the gold standard if it misses more than the plasma. So tissue is not the gold standard on assessing the tumor biology that needs treated. The plasma liquid biopsy is. And there have been other studies that have repeated the same findings. This is just an example of the power of what a liquid biopsy can do to identify the prognosis of a patient. And just by simply the number of DNA or RNA alterations seen, just standard mutations, passenger mutations, you literally just count on your hands. In the metastatic cancer, if you don't shed any, your outcome is much better than if you're shedding a lot of ctDNA, which has 2 important impacts. The more ctDNA you're shedding, the more mutations seen, the more aggressive the cancer. And now we have a variety of regimens, and some on the mild side, some on the more aggressive side. So clearly, clinically, then that would indicate this individual needs to have more aggressive treatment. More and more, we're getting to the point where a lot of treatment is given before surgery. One could argue that, boy, if you have a lot of mutations, absolutely, you shouldn't delay the systemic treatment. The surgery is vitally important for the local treatment, but it's the systemic treatment that's really going to change the metastatic outcome. And third, and it's always a tough, very tough discussion, because I always tell patients, we'll never give up on you and we'll never give in to your cancer. But sometimes the honest discussions still have to happen. And the more mutations seen may lead a discussion to be just focus on your remaining quality of life. Because so many times an individual can go through a lot of cancer treatment and it really didn't have much of an impact. And what you're always asked is, if we would have known this earlier, we wouldn't have done this. And this can be a way to help you have a sense of making those decisions in concert and connection with the patient's and family wishes. This is just an example, and it's just looking at 4 different sites of a cancer. And each site will have some trunk mutations and some other mutations, but then they will have some individual mutations. And if you biopsy the lung, there's a CDH11 mutation, and don't worry about the mutations, abbreviations, that's not the point. But if you biopsy the liver, you would find things completely different. And that's the case in other studies. You can biopsy multiple sites within the same organ, different organs of the body, and there will be a lot of heterogeneity, where there have been studies where a liquid biopsy can overcome that, because it can identify what is the cancer clone and cells that are spreading, that need to be targeted. If you just biopsy one area, you may end up with incomplete information that you miss what's the most important thing. But with a liquid biopsy, you find what's the most important thing. These are patients with metastatic breast cancer. When they looked at the tissue molecular findings and they even matched the therapy, there was really no benefit. But when they looked at the plasma, when they looked at the liquid biopsy and they matched their therapy, there was a very significant benefit, extending what a liquid biopsy can do. It is identifying the cancer cell clones that are metastasizing, and therefore identifying what treatment needs to target, not what's necessarily stationary in the tissue. When to get a liquid biopsy? Certainly, anytime a cancer recurs or progresses, if it's getting worse, you need to repeat a liquid biopsy, because every time a cancer progresses or recurs, it is a different cancer than what it was the first time. And we advocate an early 6 to 8 weeks for an early treatment response monitoring. But certainly, always at the time of diagnosis, to guide the initial treatment. And sadly, tissue molecular testing is not getting done. Even when oncologists will say that I'm getting this testing, the chart reviews don't support that. This was a chart review of metastatic lung cancer, and only 22% of patients were tested for all the recommended guidelines. Now, with a simple liquid biopsy, you find more mutations in tissue. It's a simple blood test, and you can get it back in a third of the time that it takes for the tissue molecular testing. And what's so vitally important that's now being understood is that time does matter for survival, no matter what the stage of a cancer. And everybody talks about what's the turnaround time of getting your liquid biopsy compared to somebody else. What's the turnaround time of getting a tissue next generation sequencing? It's not the turnaround time of the test that matters. It's the time from diagnosis to treatment that matters. These are across all stages of lung cancer. If you look at the Kaplan-Meier survival curve, the black line is doubled compared to the gray line. There was not a treatment difference. The only difference was the black curve tracked patients treated within 30 days from diagnosis. The gray curve tracked patients treated more than 30 days from diagnosis. Time is that important, and the time from diagnosis to treatment is what matters.
Updated analysis showed that OSI as first line versus first generation had shown survival benefit. So this picture, what does this show? Right now, the data we have, it seems like osimertinib is the winner, but the race has just started. We have many others. And as I told you, I think there are like more than seven randomized trials running in China for third generation tyrosine kinase inhibitors. So next question, what are the unmet need in the 3G era, especially osimertinib? One, inferior efficacy against exon 21 mutation in FLORA trial. Number two, lack of overall survival benefit in Asian subpopulation in updated analysis of FLORA trial. And primary resistance mechanism like MYT amplification, HER2 or MYC amplification, and secondary acquired EGFR 797S mutation, which we'll be talking about later. Do we need more 3G TKIs? Yes, because currently, except China and South Korea, basically osimertinib as a 3G has monopoly. So we need more for most cost effectiveness and addressing the unmet needs. So another question, is OSI, should we be using OSI as a first line in metastatic non-small cell cancer, EGFR mutant? So this is one study from Journal of Medical Economics by our colleague Muhammad Ismail Abdul Aziz. So based on that, see this is subgroup analysis of overall survival, New England Journal of Medicine 2020. And you see Asian versus non-Asian. So there is no real survival benefit in the Asian population. So based on that study, their recommendation was, although it's not standard of care, that OSI is not cost effective, should not be considered cost effective as first line in Singapore due to very high cost. And other first generation or second generation like afatinib, we can try afatinib, gefatinib, but this would require further studies. Resistance. So because as we have moved to 3G, so we'll see more and more cases of resistance, secondary resistance. And one big issue would be this 797S mutation. And this is usually currently pan-resistant to OSI, lerazatinib. So there is the need when we want to go ahead and develop fourth generation TKI, which should be effective against even triple mutation. So one of the resistance what are the basically resistance mechanisms? Why does the resistance develop? So One is you have on the middle histological transformation. It transforms itself into small cell or otherwise. And there are some biomarkers. Even if you do NGS at baseline and you have TP53 or RB1 mutation, these patients are very high risk for developing transformation. So you can predict from the baseline. Of course, the treatment, currently the data we have is not going to be much different. And then you can have acquired EGFR mutations. We suggest there are many, but one of the most common is 790M, 797X or S is same. Or the other mechanism, which is either c-Myc or HER2 amplification. So how do we manage this? I'll just quickly go through it. We all know if this is non-systemic, you basically, it's a slow progression. You just continue and go for, or non-CNS local or oligo progression, you go for local therapies like RFA, like surgery, and then continue. But in case of CNS progression, if the patient is stereotactic candidate, you go for stereotactic surgery. The lesion is just small and you can do that and continue OC. But if patient has leptomeningeal disease or not a stereotactic candidate, one way would be to increase the dose of osimertinib double, 160. Or of course, if there is no identifiable target based on, biopsy is a must. If you re-biopsy and you cannot find another target, you go for the whole brain radiation. So this is just a brief summary of what I've been talking about, that when the resistance develops, you have basically 4 mechanisms. Number one, histological transformation. We can sort of predict that if we have an NGS at baseline. Off-target mutations, 30 to 40%. And interesting is MYT, HER2, BRAF, and RIT mutation, for which we have now trials running. So the standard of care still is chemotherapy, or you give immunotherapy or VEGF inhibitors. On target, if we have EGFR like 797S, we'll be talking about that. And of course, if there is no identifiable mutation, you treat as if it was wild type. So this is not about, this is about internet. Many countries have 5G, and in 2030, we'll have 6G. So 4th generation tyrosine kinase inhibitors. So one of the agent, the basic data was presented in 2020. I think it was ASCO meeting. It's BLU-945, and we have the Symphony trial running. It's an international trial, phase 1, phase 2, in which basic eligibility is that patients should be exposed to at least one EGFR tyrosine kinase inhibitor, but it has excluded exon 20 insertion and other kinase mutations. So it started, and it will be running, and it's open for enrollment. Novel approaches. So what other approaches people are thinking about? One of the approaches, this discovery and use of this bispecific antibody, amivantamab, which is a bispecific antibody targeting EGFR as well as the MYT. So it has basically 2 arms, one anti-EGF arm and the other is anti-MYT arm. So you can engage both. Mariposa trial. Mariposa is an Italian name for the butterfly. So this is the trial which is running, and it's one of the novel approaches in which you combine a TKI like lazertinib with amivantamab and compare this combination to either single agent OC or lazertinib. So this trial is enrolling. Important to note is that this bispecific antibody has activity in exon 20 insertions, for which we previously had absolutely no treatment. And this dual blockade would be really exciting in the future, that can we suppress the emergence of acquired resistance to EGFR and MYT amplification? And this is the basic scheme of the Mariposa trial, a bit complicated. You combine a TKI with amivantamab versus osimertinib versus lazertinib. So it's an ongoing trial. All right. So I'll start firing. I'm not good at firing, but still. Chemo plus TKI, I just skipped through it. We don't have data for 3G, FLAURA2, trying to combine OSI with chemo across 1, across 2. VEGF inhibitors, we have data for combining Cyramza with erlotinib, but with OSI, we don't have data as yet. We have the trial running. All right. What about the ADCs? So the drug conjugates. So previously, patritumab alone was not effective, but when you combine it with a cytotoxic payload, we have the trial running. This is Herthina. Because of sake of time, I'll just quickly go through it. It's just phase 1, phase 2 study. It's one of the ADCs still running. Other mutations beyond EGFR, one we discuss is MYT amplification and HER2 amplification. And although chemotherapy is the backbone, but still we have, this is how we have learned about the MYT pathway. I cannot explain, and the slide is really blurry. Because of sake of time, we have moved on from antibodies to now MYT selective TKIs. And one of the studies is this Insight 2 study, which is which is testing tepotinib, which is a MYT selective TKI. Exon 20 insertions, just this is the last component. This is the third most common for which we had total resistance to standard EGFR TKI. And first line was similar. And even immunotherapy, they excluded keynote 024, 042 without any EGFR mutation. So we have now data coming up for amivantamab as well as mobocertinib, which is basically active against exon 20 insertion. And this data has been presented in National Paris meeting this September. This just shows that this exon 20 insertion is number 3. It's not that uncommon. This is mobocertinib, which is basically an orally reversible EGFR inhibitor. Amivantamab we already discussed. And we have emerging agents, complex names. I'll just quickly go through it. And novel agents entering. Even exon 20 insertions, you can have intrinsic and extrinsic resistance mechanism. And there are still unanswered questions, like we have Adhura questions regarding Adhura. So there are many other Adhura questions regarding this exon 20 insertions as well. What about uncommon EGFR mutations? What will we do about that? So afatinib is the only TKI approved for 3 uncommon mutations. And this is based on 3 trials. But you can use OSI as a baseline. I'll finish here. Thank you so much.
So thank you, Dr. Azad. So we'll quickly move to our next speaker, who is again going to be a virtual talk. And the topic is update in lung adenocarcinoma with non-EGFR mutations. Dr. Manish Thakur. He's a clinical assistant professor from Michigan State University, US.
Hello, everybody. My name is Manish Thakur. I'm a medical oncologist here in United States, Michigan, Grand Rapids, assistant professor at Michigan State University. It is in my honor today to talk about update in lung cancers with non-EGFR mutation. It's quite a broad topic, and I'll try to squeeze as much of it as possible in the next 20 minutes. So let's jump into it. So it's an exciting time to be treating non-small cell lung cancer, metastatic, stage 4, with the multitude of treatments. As you all know, it's important to test everybody, commonly adenocarcinoma, but also squamous cell carcinoma, who are stage 4 for all these mutations. I'm sure you've had a great discussion about EGFR mutations so far. I'll talk about the other genes. So when I see a patient with non-small cell lung cancer in my clinic, stage 4, I tend to ask the question whether it's a mutation, rearrangement, or amplification. It helps me make the conversation easier with the patient. So these are all the mutation, rearrangement, and the amplification, and we'll go through these one by one. These are the current NCCN guidelines about all the treatments available, and we'll talk about most of them. The PD-L1 or immunotherapy is covered by a different speaker. I'm going to start with rearrangement. So what is a rearrangement? So there's one gene and then another gene from another chromosome fuses together and it forms an abnormal protein. So we'll start with the ROS1. So currently, ROS1 affects about 1 to 2% of lung cancers. It's a translocation between ROS and other genes, most commonly CD74. These patients tend to be younger, never smoker, and it used to be detected by something called break-apart FISH. I'll show you an example when we talk about ALK, but these days we detected by NGS panel. So the first drug to talk about is crizotinib. Its target is not only ROS but ALK and MET. It was a ALK inhibitor to start with. So in this trial, there were 53 patients. Overall response rate of 72% and very nice overall survival of around 51.4 months. This is the trial. You can see the waterfall plot for best responses, pretty dramatic. The second drug is entrectinib. So it's both a ROS and an NTRK inhibitor. Again, overall survival in 70s, close to 77. PFS of 19 months. Overall survival in this trial has not been reached as yet. So again, this is the waterfall plot for the patients treated in this setting. Other options listed are ceritinib, lorlatinib, and mind you, chemotherapy has not gone anywhere. So pemetrexate-based chemotherapy tends to be very effective, not only for ROS, but for ALK and other rearrangements. Repotrectinib is a newer kid on the block, currently tried in trial. It's a phase 1-2 trial that has shown an overall response rate of 79%. It does have the most common adverse event of dizziness. So these are the ROS1 rearrangement positive lung cancer treatment options for you these days. We'll switch to RET rearrangement. So just like ALK, RET is when you have a partner that translocates to RET, it becomes cancerous. It affects 1 to 2% of non-small cell lung cancers. Patients tend to be younger, never smoker. There are a couple of drugs that are approved right now. I'll first talk about selpercatinib. It is approved for RET fusion positive lung cancers. It was a phase 1 trial, 39 treatment naive patients, overall response rate of 64% with a median response duration of 18 months. The second drug is pralasetinib. It was based on the ARROW trial, again a phase 1-2 trial, 281 patients, overall response rate of 72% in treatment naive and 15% in pre-treated with a duration of response of 22.3 months. There are other treatment options: cabozantinib, vendetinib, alectinib, sunitinib. Problem is these are multi-targeted TKIs. For those of you who treat cancers other than lung, you must have used them in liver or kidney cancers. They tend to have a lower response rate and more side effects. I'll switch to ALK. This, as you know, ALK is a little more common, not very common though, 2 to 4% of the patient. This was what I was talking about, break-apart FISH. So basically, when the EML4 gets translocated between the ALK gene, there is this signaling. So if the two are together, the signal tends to be yellow. But if you have an EML4 inserted, the red and green show as a break-apart. So that's how these fusions were tested. Nowadays, NGS panel pretty much is capable of getting these mutations. So there are first-generation ALK inhibitors that used to be crizotinib and ceritinib. They've fallen out of favor. Second-generation ALK inhibitors, alectinib, brigatinib, lorlatinib, are the ones that we use in clinic. So this is the timeline of ALK inhibitors. We started off with crizotinib, and now we have these second-generation ALK inhibitors. I just wanted to show you the trials that got these ALK inhibitors approved. Alectinib, it tends to be my personal favorite. There were 2 trials, the ALEX and the JALEX trial. The ALEX trial, difference is JALEX was in Japan. So These are all first line. Control arm was crizotinib. Alex had a survival benefit in these trials. The overall survival was not reached, and about 57 months for crizotinib alone. There was 53% reduction in risk for progression and death. The Alacia trial was a phase 3 trial of alectinib versus crizotinib, PFS of 0.22, and overall survival of 0.28, pretty convincing. The common side effects of alectinib that we see in clinic are usually anemia, increased bilirubin, weight gain, and photosensitivity. Brigatinib approval is based on the ALTA-1L trial. It was a trial that again showed good PFS, overall survival benefit. Brigatinib in clinic have used it, and even in clinical trials, it showed common side effects of ILD, about 3 to 4%. How do we mitigate that? We start them on phase doses. So you start them on 80 milligrams and then Q daily for a week, and then you can escalate the dose. Lorlatinib approval was based on the Crown trial. Again, nice PFS and overall survival benefit here. Lorlatinib tends to be very well tolerated. Hypercholesterolemia, triglyceridemia are some of the common side effects. I mean, with these drugs, you can pretty much put the patient on an ALK inhibitor and then forget about them, kind of a thing, instead of chasing them very frequently. They tend to be very well tolerated, very nice PFS and overall response rate. Now, these are inhibitors, so they are not like, they don't work like some of the immunotherapies. So sooner or later, they do progress. Most commonly, the mutation that they develop is in the ALK domain, commonly the L1196M mutation and the G1269A. There are other bypass mutations that can happen, MET amplification, skipping mutation, RET, EGFR. The bottom line is, whenever a patient progresses on these inhibitors, it's important to test. So test again. You can start with a blood-based testing, and then if that doesn't work or doesn't show a mutation, you can always do tissue testing. So this was a paper from Shaw et al., NEJM 2016. In this particular patient, the patient was started on crizotinib, developed a resistant mutation, was switched to lorlatinib, and then got resensitized to crizotinib. So the bottom line is test. Whenever a patient progresses, test for mutation, and you might find a certain type of mutation that you can target. So these are all the treatment options for ALK inhibitors that are approved right now. Again, my choice and the common choice these days is second generation ALK inhibitor. Alectinib tends to be pretty much favorable. One important thing, all of the ALK inhibitors, second generation ALK inhibitors tend to have good CNS penetration, and ALK rearranged tumors tend to have an easy predisposition of going to the brain. So, whenever feasible, start them on second generation ALK inhibitor. All right, so KRAS used to be a big problem in the sense that you would test your patients, and KRAS used to be the most common mutation, but we couldn't do much about it. It affects about 20 to 25% of patients of lung cancer, who most commonly are smokers, as compared to other mutation or rearrangement where you tend to have females and never smokers. Sotorasib is a drug, an oral TKI that has been found to have good response in second line setting. So based on a phase 1 trial of 129 patients, all heavily pre-treated, at least one line of treatment, PFS was 6.3 months with a 88% disease control. The most common side effects were LFT abnormality and hepatitis. The first patient I treated with this medication developed significant LFT abnormality. It was with dose reduction, it was possible to put them back on treatment. Adagrasib is recently approved in the United States. It's based on a single arm, 116 patient trial, again showing a response rate of 43% with an OS of 12.6 months. Let's switch to HER2 mutation. So those of you who treat breast cancer, it's a common thing for you to treat, but lung cancer, it's a newer mutation, affects about 1 to 3% of lung cancers. There are either small in-frame or point mutations in exon 20. Now, mind you, this is an exon 20 that's different from your EGFR, so you have to be careful when you read these mutation. Again, adenocarcinoma, never smoker, females. Trastuzumab deruxtecan. So it is approved second line. It was based on a phase 2 trial, previously treated, overall response rate of 55% with a median duration of response of 8.2 months. I tend to use it in second line. If you are lucky, if you find approval, you can use it in first line. Very well tolerated. Based on the trial, there were side effects of nausea, fatigue, neutropenia, anemia, diarrhea. Honestly, I've not had a significant problem with this drug. Did have some episodes of transient bone marrow suppression. Erotrastuzumab emtansine is also based on a phase 2 basket trial of 18 patients, 2 or more prior lines, response rate of around 44%, PFS of 5 months, median duration of 4 months. Something that you can think about, but again, you can always choose standard chemoimmunotherapy in these patients. MET exon 14 skipping mutation is also something to look for. It affects about 3% of adenocarcinomas. If you have a specific variety of lung cancer with sarcomatoid variant, you need to test it for sure, because about 1/5 of these patients will have the exon 14 skipping mutation. You can also target MET amplification, and we'll talk about it at higher levels. MET amplification tends to be a form of resistant mechanism. So this is what happens. Exon 14 is flanked by introns. When you have deletion or splicing mutation leading to the changes in these introns, it sort of skips. So when the protein is transcribed, there is no stopping, and then it leads to carcinogenesis. 2 drugs that are approved in this space are capmatinib and tepotinib. Capmatinib based on the Geometry Mono-1 trial, which showed a 68% response rate in treatment naive and 41% in pre-treated patient, PFS of anywhere from 6 to 12.4 months. Tepotinib is based on a phase 2 trial, overall response rate of 56%, regardless of treatment line, and 8.5% PFS. So when I was talking about high-level MET amplification, if you see MET amplification, if it's more than 5-fold increase in copy number, you can place them on capmatinib and crizotinib. I would not try to place them on these if they are less than 5%. It doesn't seem to work. Okay, BRAF mutation. So this is a newer mutation that's most commonly seen in melanomas, and for those of you who have treated melanomas, fairly common with this treatment regimen. This was a phase 2 trial of testing dabrafenib and trametinib. This was just for BRAF V600E mutation lung patients. Right now, for non-V600E mutation, we don't have any good treatment options. Based on this trial, the overall response rate was about 68% with a median PFS of about 10.2 months. So I did want to spend a little bit time on NTRK mutations. So as you know, NTRK mutations tend to be rare, less than 1% of the patients. You're looking for fusion, so it can be NTRK 1, 2, and 3. The 2 drugs that are approved right now are larotrectinib and entrectinib. These were tested on all solid tumors, so not specifically lung cancer, given the rarity of the mutation, but the overall response rate was anywhere from 60 to 70% to as high as 79% in these trials. Both larotrectinib and entrectinib tend to be very well tolerated. Again, as I pointed out before, entrectinib is also used in ROS1 tumors. Lastly, NRG1 fusion. This is also something that is rare, less than 1%. Not yet targetable. Fatinib has shown some partial radiological responses. The one thing that you have to understand is NRG fusions tend to have poor responses to chemotherapy. There is a newer drug in the market. It's called seribantumumab. It's still under trial and is of some promise. Some of the important aspects about these mutations are, when you find, so you have to first look for these mutations. once you find these mutations, you better try putting the patients on first line for most of these mutations. The only mutations where you can and have to sort of use first line chemoimmunotherapy is KRAS and BRAF. Other than that, all the rearrangement of and mutation not only has immunotherapy shown to be inferior to targeted therapy or chemotherapy, it has also shown in trials to cause side effects. So when I have a patient with BRAF or with KRAS, I tend to use the standard algorithm of PD-L1 testing, and if PD-L1 is high, put them on Keytruda alone, or low immunotherapy with chemotherapy combinations. But when I have ALK mutations, MET amplifications, RET, HER2, I tend to try to see if I can get approval for first line targeted therapy in most of them. The other important aspect is whenever you see an ALK mutated lung cancer, always think about CNS metastasis and to put these patients on second line ALK inhibitors to prevent this CNS mutation. Again, I tried to squeeze so much data into this short amount of time, but again, thank you for giving me this opportunity, and hope you guys have a great day. Thank you.
So we'll quickly move to the last speaker, whose topic would be approach towards lung adenocarcinoma lacking driving mutation. And the speaker is Dr. Professor Jeffrey Liu. He's professor of internal medicine and oncology, and he practices in Princess Margaret Hospital, Toronto, Canada. And Jeff is also online as well at I think it's around 10 past 3 in the morning. So first of all, thank you, Jeff. And in the end, we can join with you and have question and answer sessions.
Hello, my name is Jeff Liu, and I am a professor of medicine, medical biophysics for oncology and toxicology epidemiology at the University of Toronto, and I am a medical oncologist at Princess Margaret Cancer Center. I'll be talking about the management of non-targetable, in other words, non-EGFR metastatic non-small cell lung cancer. I have a number of disclosures, which are shown here. My objectives are to review the non-targetable, specifically non-EGFR metastatic lung adenocarcinomas, and their management and treatment. I will focus primarily on overall survival, as that is our standard compared to progression-free survival. I will also focus on first line and subsequent lines of therapy using a Canadian funding model. But the first thing that I should mention is the fact that we really should make sure that we rule out targetable lung cancer in patients that are able to afford targetable drugs when they're available. Molecular testing should be as extensive as possible in never smoking and in very light smoking patients with lung adenocarcinomas. This is because a large chunk of them, anywhere between 50 to 75 to 80% of such patients will have some sort of potentially targetable mutation. Not all of them have drugs that are available out on the market, but some are available by trials, some are available by other means as well. Our old standard for non-targetable lung adenocarcinomas metastatic used to be a platinum doublet, often platinum and pemetrexed, but in previous literature, platinum and paclitaxel, platinum and gemcitabine are also alternatives. And then upon failure, movement to docetaxel. That all changed about 6 or 7 years ago. Our new Canadian standard, which I have shown here, and I use as an example, this comes from the Canadian Agency for Drugs and Technologies in Health, and is a guideline that we're using right now. The general principle is that you try to use immunotherapy plus or minus chemotherapy, depending on the PD-L1 status, in first-line metastatic disease, conditioned on whether they had recently received immunotherapy as part of stages 1B, 2, and 3 disease. In other words, earlier stages of disease. And so with that in mind, I'm going to talk about first-line therapy. The current standard for first-line therapy in most patients will include some form of immunotherapy plus or minus chemotherapy. So in patients who have not received recent immunotherapy for an early stage non-small cell lung cancer or lung adenocarcinoma, we almost always will include immunotherapy, unless, of course, the patient has severe autoimmune disease or some contraindication to receive immunotherapy. And so I will first talk about pembrolizumab and platinum-based chemotherapy, and you'll see I'll eventually talk about nivolumab plus ipilimumab plus 2 cycles of platinum-based chemotherapy for this first-line category. And so the data comes from a number of sources, and chemoimmuno definitely is an alternative. So if you look in here, Keynote 189 has probably the strongest data with an overall survival of 22 months in the green. This is the second one down from the top, as well as followed by a few trials, which I won't talk about. But what is also approved in Canada is Checkmate 9LA as well. So I'll talk about that study as well. So for the Keynote 189 study, it was non-squamous, pemetrexed plus platinum, plus or minus pembrolizumab. 5-year outcomes still show that 31% of such patients receiving immunotherapy, I'm sorry, about 19% of such patients are still alive at 5 years, which is quite striking. And that this didn't seem to matter very much depending on the PD-L1 level, whether you have the bottom left, PD-L1 greater or equal to 50%, all the way to PD-L1 less than 1% on the bottom right as well too. So most of these patients would not have completed 35 cycles of pembrolizumab, but it's interesting to note that for those who have actually completed the actual dosing, the survival is actually quite interesting. So 3-year overall survival after completing 35 cycles is 72%. And that's actually quite remarkable. So our ability to make people live longer has been quite substantially improved in the presence of immunotherapy. Keynote 189 also seemed to benefit just about every subgroup. It actually favored more never smokers as well, that you actually see there. So this is particularly interesting because many lung adenocarcinomas in Asian countries, including South Asian countries, will have a dominance of lung adenocarcinomas in the never smoking populations. For Checkmate 9LA, which I'll talk about next, this study design was that of nivo-ipi plus 2 cycles of chemotherapy, followed by nivo-ipi afterwards, versus 4 cycles of chemotherapy until progressive disease or toxicity. The primary endpoint was overall survival, and it met its outcome, where you can see that at 2 years, the overall survival was 38% versus 26% in this case. There are a few things to know about the subgroups. The non-squamous subgroup didn't do quite as well as the squamous, but those patients who had CNS metastasis did appear to do significantly better than the chemotherapy groups. So that will be a subgroup that you may want to consider giving Checkmate 9LA. When we look at toxicities between the Keynote 189 versus the Checkmate 9LA on the right, there was slightly higher rates of nausea and pyrexia in the Keynote 189 group, and slightly higher rates of musculoskeletal pain, rash, pruritus, headaches, and dizziness in the 9LA experimental arm. One thing of note is that nausea and GI symptoms as well as pyrexia was also higher in the control group of Keynote 189 versus 9LA. And we do know that pembrolizumab itself probably has fewer side effects overall than that of a combination of nivo and ipi. So for many of us, we tend to be giving the platinum, pemetrexed, and pembrolizumab combination way more often than we would 9LA. And in certain circumstances, such as those with brain metastasis, we would consider it. And particularly in patients really wanted to lose the chemotherapy very early on. They didn't really like the chemotherapy. The 9LA gave only 2 rounds of chemo, whereas the Keynote 189 gave 4 rounds of chemo. So that would be a patient preference. I'll quickly talk about Empower 150 because as well as Empower 132 and Empower 130. Empower 150, I'll talk about in a second, but Empower 132 was a negative trial from overall survival, although it was positive for PFS. And Empower 130 had a weird comparator group. And in fact, the base chemotherapy was carboplatin, NAB, paclitaxel. And of course, we don't have NAB paclitaxel approved in Canada for use in non-small cell lung cancer. So it wasn't particularly useful for us as a trial, and we don't give it. We also find that the Empower 150 was used really expensive drugs, used a lot of time in chair time in terms of chemotherapy, and also in terms of a comparator. It had an unusual comparator of bevacizumab, platinum, and paclitaxel, not something we commonly use here in Canada. In fact, it's not approved in Canada. So as a result, Empower 150 was something we thought was too expensive and not worth its worth compared to other things that are out there. We generally use pembrolizumab with chemotherapy in the setting Keynote 189 with checkmate 9LA as an alternative in specific circumstances. And here's the data for the 4 drugs versus the bevacizumab, carboplatin, paclitaxel. So now there are subgroups of patients in which immunotherapy might be quite good already. And if you look at the overall survivals, you will notice that Keynote 24 had a 30-month median overall survival. Checkmate 227 had 23, but I'll also talk about why it's not particularly being used much by us here. And Empower Lung 1 showed that simulpimab also had a 26-month overall survival in this case. And so these are the 3 that I will be talking about and focusing on primarily. Our Canadian standard lists only pembrolizumab and cemiplimab, and I'll explain why in a minute. Keynote 24 used pembrolizumab versus chemotherapy, and this is an older study. And basically, this is the one at 5 years, almost 1/3 of patients, 31.9%, ended up with being alive in the pembrolizumab arm. And this is very striking of note. The toxicities are as we expect. We're all very used to, I think, pembrolizumab monotherapy. Nothing too strange about that. Retreatment after completion of 35 cycles was something that was also done in the study. And in most of Canada, retreatment for 1 year after completing 2 years of treatment, 35 cycles is 2 years, and at least a 6-month break in between was adequate for us to have it funded. And being how expensive these drugs are, that was quite a feat. Now, those are the patients that we would use when the PD-L1 is greater than 50%. So one is pembrolizumab and one is cemiplimab. So cemiplimab, the original study compares cemiplimab versus 4 to 6 cycles of investigator's choice of chemotherapy. There was also optional continuation of cemiplimab plus onwards, and optional crossover in the investigator's choice arm as well too. And about 1/3 of patients did so. At 3-year follow-up, there was significantly longer overall survival in all cemiplimab patients, but particularly if you look at the bottom, in those that had PD-L1 greater than 50%. That's where you get the 26.1 median overall survival in months. Interesting enough, Empower Lung 1 also showed that for cemiplimab, the degree of PD-L1 mattered as well. So the higher the level of PD-L1, the greater the drop or the change in baseline in the size of the target tumor was actually observed. And to some extent, this was kind of seen in the overall survival and the progression-free survival curves as well too. Those patients with higher levels of PD-L1, the highest levels, benefited the most. Of note, though, the non-squamous group didn't do quite as well as the squamous group. So this is something to keep in mind since we're talking about lung adenocarcinoma in this particular setting. Overall, the safety summary is quite reasonable for cemiplimab. There was nothing that was out of line with what was expected with other IO agents. So that leaves only CheckMate 227. And in this particular graph, you will see why in the group that's greater than 50%, that there is some benefit to using Nivo-Ipi in those that have PD-L1 greater than 50% versus chemo. For many of us, giving 2 drugs with the higher toxicities didn't seem to be worth it when we had quite good drugs that was monotherapy and anti-PD-1 and PD-L1 drugs that were available. So that leaves the point of when do we use immunotherapy in second line? Well, that's really only in the subgroup of patients who, for whatever reason, didn't get platinum-based chemotherapy in the first line, but on the other hand, did not have an absolute contraindication, or maybe had a contraindication that was relative to, and therefore wasn't used initially. But then there's still the option to use it in second line. And this is really older data, so I'll go through this really quickly. CheckMate 57 was that of nivolumab that showed the benefit of nivolumab if you look at the top left in second line and beyond, with quite interesting survival, 2-year survival of 23%. A quarter of those patients were alive from the date of counting of the start of second line therapy. Quite remarkable. Poplar and Oak are 2 studies that looked at atezo and definitely found the same thing as well. And so in here, they even had a 4-year overall survival from the time of initiation of second line therapy of 15%, making it to 4 years. And at 2 years, you can see somewhere around 30% was still alive as well too. Again, quite remarkable consider what we're used to seeing in these olden days pre-immunotherapy. And also, we have that of pembrolizumab in those in this case that are in particular over 1%. I'm sorry, that shouldn't say over 50%, but I've shown the data for over 50%. You see benefit in any of those patients at over 1%, but you see the most benefit from those that are over 50%. And particularly those who are adenocarcinomas and are wild type in nature. So it is important to keep in mind a couple of things that I will talk about, which is the fact that the addition of chemotherapy onto immunotherapy seems to be the big question these days. Immunotherapy appears to be the backbone in any patients who have non-targetable lesions. Once you root out the actual targets, immunotherapy should be considered first unless there's a contraindication. And the question is, when do you add the chemotherapy? Well, you add it when the chance of success is lower. So when the PD-L1 is less than 50%, and or if you think you need a benefit quickly. So even those who have high PD-L1, if they're very sick, they have high bulky disease, you may want to start with chemo and immuno together in that setting. You may want to consider CheckMate 9LA, particularly in patients with brain metastasis. But in many cases, you may want to just add in the pembrolizumab to your chemotherapy. And that will be fairly well tolerated to this extent. And so my summary is pretty straightforward. It is the fact that immunotherapy has gone from being non-existent 10 years ago to being the backbone of treatment of metastatic non-targetable non-small cell lung cancer. And the big question these days is, when do you add chemotherapy and in what settings? And I've explained those right now. And you now use really immunotherapy in second line when you have, for whatever reason, forgotten or found it inappropriate to use in first line therapy. And the results are actually quite remarkable. We talk about the tale of tales in this case, and that is that the majority of people still won't benefit, right? You'll see the curve move a bit, and the median overall survival being better. But it's that tail, that group of individuals that have derived long-term benefit. Well, we believe that the immunotherapy has profoundly changed the immunosurveillance that is going on in the person's body so that it's killing off whatever remaining cells or keeping them in check of these cancer cells, and allowing these people to live much longer. And that tail is where we hope, where we might get the longer term survival, even beyond 5 years. So with that in mind, thank you very much for your time, and I look forward to answering questions during our next session. Thank you.
So now we move to our question answer sessions. So can you just make Jeff online? I think he's already joined online. So he's online. Can you place the screen over here? Can we see him? Is he sharing the video or is just the audio? Thank you, Jeff. Can you hear me?
I can hear you, yes. Can you hear me?
Yeah, sure. So it's 4 a.m. I think it's 9 minutes past 4 in the morning. And thank you very much. Like, you are a stallion over here who is he's completely awake at this in the morning. So we'll move to a few of our questions from the panel. So Jeff, we have like 3 of our oncologists. One was Dr. Azhar, the other one was Dr. Zishan, and the other one was Dr. Tahir. So I think I'll just start from the first question. How you treat ALK positive and EGFR positive, like mutually they are both positive. How you treat this cancer? So maybe like I can ask, everybody can chip in. But Doctor, I'll start with maybe Dr. Azhar. You gave a talk on EGFR positive cancer. So can you just let us know?
So I think the data on this is limited, but when you have concurrent, either primary or acquired EGFR with ALK mutation, you can add an ALK inhibitor, of course, with a concern that the toxicity would be high.
Thank you, Dr. Azhar. Any? Okay, so Jeff, would you like to comment? Like ALK positive, sure. EGFR positive. Sure. I have 2 patients of mine, so I'll let you know what's been happening with them. But can you just comment on this?
Yeah, I've had 2 myself that are a combination ALK and EGFR. The first patient we've actually treated with ALK, with an ALK TKI. At the time, we weren't allowed to use 2 different drugs at the same time. And the patient actually did well for 4 years before relapsing. And at the time of relapse, we switched over to osimertinib from alectinib, and the patient responded for another 1.5 years. So it sometimes is unclear as to which drug would derive the most benefit, because it's sometimes unclear what's driving the actual tumor. Our second patient didn't respond to an ALK inhibitor initially, so we added osimertinib within 2 months, and then the patient did respond. So that patient is in a combination of brigatinib and osimertinib. The toxicities of the ALK inhibitors and the toxicities of the EGFR drugs don't overlap as much, especially when you're using the drugs such as alectinib, brigatinib, or lorlatinib. So we've actually found that patients have been tolerating that reasonably well. I guess my experience of 2 patients. I'm curious to see how you've treated it and what your results have been.
Yeah, Jeff. So basically, in those both patients, we have we don't have, like, we have ALK inhibitor, alectinib, but most of the time in our setting, the main thing is the cost. So patients, most of the patients cannot like afford a per month cost for alectinib. So what happened in both of my patients, I was like, even a third generation TKI like osimertinib was not affordable. So to be very much honest, we started on erlotinib. These both patients have crossed now 12 months and they've been doing very well. So this is what we have done, because we were thinking like, should be giving erlotinib, which is quite cheaper in our country and it's readily available. Osimertinib needs to be imported in our country. It takes around 8 weeks. So these are a few things which are like we have to adopt according to our logistics and circumstances.
So I'm also curious about one thing though. When I visited India a few years ago, they were using I guess I won't call it generic, but a knockoff version of osimertinib that was coming from Bangladesh. Is that also used in Pakistan, or that's not done? Because I'm always curious to find out if one would be getting similar results with such a drug.
So Jeff, in our hospital, like where I practice, usually like these all drugs from like India, Pakistan, they come through a non-proper channel. So most of the time, these drugs are available at a cheaper price. And I think out of Shaukat Khanum, most of the doctors are using this medication. However, at our place, we cannot get these medications because they've been not allowed to be used as they are in black market. So I think Azhar can share, because in their hospital, they've been using Bangladesh and Indian medications, and he can share his experience.
First, just a comment. I think the terminology black and white is quite subjective. The way you look at it is the way you look at it and where you sit. Yeah, we have lots of patients on osimertinib, and this is very easily available and at a fraction of price as of AstraZeneca. Yeah, it's very, very easily available.
So Jeff, for you, there is one question from one of our panelists. So please, Dr. Azhar, go ahead.
What about the results or added toxicity? So because we don't have a trial ongoing about the alternate option, but I haven't come across any unusual toxicity like reported, like interstitial lung disease or anything really terrible, no. And what's the maximum duration of patient have been using more than a year?
They were effective. Most important thing is they're effective. So Jeff, this is a question from you.
Thank you, Dr. Lou, for a wonderful talk. I'm a community oncologist from Faisalabad, just 120 kilometers away from Lahore. I have a question from my clinic. I have a 34-year-old gentleman who is suffering from metastatic non-small cell lung cancer. He was mutations negative. He had a PD-L1 around 10%, and he was put on platinum-based doublet and immunotherapy. He responded wonderfully. After completing 6 cycles of chemotherapy, like it's last week, he received his 42nd cycle of immunotherapy. And PET-CT 6 months ago was negative, except few sclerotic lesions in the bone. No, he's really scared of disease coming back, and we have no answer for how long to continue this immunotherapy and when we need to stop it.
Yeah, so when you're saying 42 cycles, this is the every 3 weeks?
Every 3 weeks.
Okay, yes, yeah. In Canada, because of COVID, we had switched over to the double dose every 6 weeks. So I just wanted to get a sense. Yeah, so we're in the same boat. We have patients, because of the public funding system here, they get the equivalent of 35 every 3 week cycles, and then they're cut off. At the time of relapse, if they do relapse, if they relapse at least 6 months later, they get another 12 months worth of treatments. So that would be about 17 more doses of it, and then they're cut off again. So now I have patients that are 5, 6 years out, and the disease is starting to act up again. And some of them are actually paying out of pocket at this point, or I've been lying in saying they have a new cancer. So I can start the cycles all over again. It's a bit amazing about the fact that in some of these cases they will respond if it comes back again, but it leads to the question of, maybe we shouldn't stop it if they're tolerating quite well. It's just an extraordinarily expensive thing to do on a long-term basis with no particular end. So I don't have an answer to this at all, and I think the data is very, very limited, other than anecdotal. I don't know if I answered your question at all.
My name is Ishan Tariq. I came from US two months ago. So I think at this time in US, nobody is courageous enough to just hold immunotherapy, especially when patients have been doing so well. At this time, we have seen patients on immunotherapy for so many different indications, and they have been on that for 2 years, 3 years, 4 years, 5 years. And at this time, at least in US, we're not holding that. So down the line, if we have more data, that's something different. But at this time, I don't think anybody in the US is stopping it.
I think the big question is that it's easier not to stop it as long as someone's willing to pay for it. It's a much harder question of is anyone brave enough to actually stop it outside of a public pay system. So I totally agree. If I had my druthers, I would keep my patients on it for as long as possible.
So sorry, Dr. Azhar. So Dr. Badr is also here. And thank you, Dr. Badr. I think it's early in the morning in UK, and you are with us as well. So thank you for joining online.
That's okay. Yeah?
Please go ahead.
I just have a question from Prof. As we have the results of FLORA trial showing no survival benefit with osimertinib as the first line in the Asian subpopulation. So what are your comments? Like, if we do upfront NGS and we do not find a 790 mutation, so do you think it's rational, especially Dr. Samir has also mentioned the cost is really prohibitive. What's your comment about that?
So Jeff, can you hear me?
Oh yeah, I'm sorry. I heard pleurofusion, and I thought that was being directed to Dr. Gene.
No. So Dr. Badr is also online. I just welcome him. So Dr. Azhar wants a quick question. Dr. Azhar.
I'll rephrase the question. In Asian subpopulation, so we had some studies that OC is not as effective in the Asian subpopulation. In fact, not a great survival benefit. So in our part of the world, should we try it as first line or as a second line?
Yeah. So I think there are a few ways to look at it. In the original secondary analysis, for the first line FLORA trial, there was not as much benefit in the Asian population relative to the first generation, right? So I think in this particular sense, and in my travels through India as well, the sense was that it may be very worthwhile to just start off with the cheaper first generation drugs, and then switch over to the osimertinib at the time of failure if you can document T790M. The trouble that I have with all of this is that in Canada, our experience has been that because osimertinib is funded, that we started in all patients. And I would say the vast majority of the patients that I see are South Asian, Southeast Asian, and East Asian. And we're not finding that osimertinib is doing worse in our populations of Asians. So I don't know whether there are differences between South Asians and Southeast Asians and East Asians, but I would say about 20% of our patients are actually from the Indian subcontinent. We're not finding that much difference. Our median progression-free survival in our real-world data is 21 months in South Asians and 22 months in East Asians. So I don't know if there's differences in other aspects when people move from one country to another. So I'm not exactly sure how strong this data is. We certainly are not finding it in Canada.
So I have a quick two questions from one of the online audience. So the other one is like they've asked re-challenging immunotherapy in a patient with a PD-L1, like Jeff, you have already spoke about it and you have touched that second line immunotherapy. But the real scenario what they have shared is like there's a patient who got atezo carbon Alimta, and later on around 7 months later she progressed and she was started on dosi and ramucirumab. She responded very well. Now again there is like again a crossroad, and now the question is, can we give like immunotherapy combined with chemotherapy again? Like it would be a technically third line setting. Just to remind, PD-L1 is like less than 1%. So we are stuck. Should we just give another third line chemotherapy? She's physically very fit. Or should we try immunotherapy?
Okay, so there is the standard answer, which is, you know, at less than 1% and really not much not a great response or long-term benefit initially, that it may not make sense to actually give immunotherapy. I've got to tell you that our experience has been all over the place, that there are some patients that didn't respond to first-line immunotherapy and then went on to something else, and at fourth and fifth line we run out of options. And so, you know, we find a way to give it again. I usually then claim that it's a new cancer. And they start responding. So I don't know what the answer is. I don't know what the real answer is. I do know that when you're running out of options, you go back. We generally don't give it third line with chemo. We often will give it sequentially. But I don't know exactly what the answer is. And I bet you anyone who practices in the US probably has more experience when it comes to this, because of this issue. So I'm curious as to the oncologist who just came back from the US, what his experience has been.
I think at this time, using immunotherapy, especially in patients who have 0% or less than 1% PD-L1 scores, I think we are not going back to immunotherapies, most of us. But I think obviously since US, we have Northeast, South, and then West territories. So there may be some practice differences, but broadly speaking, at this time, we're not going back to immunotherapies at this time.
I would also say that it's kind of weird, but about 5% of our patients, we tend to rebiopsy quite often, because we grow many of these out as primary derived xenografts and primary derived organoids. So we tend to rebiopsy all the time. We're finding discrepancies that in fact some of these otherwise cold tumors after, you know, third line and in the fourth line, they can turn hot, not usually up to 50%, but they go up to 20 and 30%. And we know there is quite a lot of heterogeneity in some tumors when you biopsy different areas. So I guess one of the things I've learned is never be dogmatic about anything when it comes to it. When you're out of other options, you may want to end up trying these things anyway. And we have found a small proportion of patients, probably about a quarter or less, where the PD-L1 has changed from the initial to a later biopsy.
There are some retrospective studies in US also where different institutes have shared their own experiences with using PD-L1 like PD-L1 inhibitors down the line as third or fourth line. I think the response rate is in the range of 9 to 10%. So again, I totally agree with you. I think biopsying is always an option, but individualized institutes, they have given us their own experiences, and that is close to 9-10%, which I think with even third line or fourth line systemic chemotherapy, we would not expect much anyways there also. But I think
that's actually quite good compared to third or fourth line chemotherapy, quite honestly, right? With docetaxel at 6% response.
So Jeff, thank you very much for joining us online. So we will end our session, and I would like Dr. Badr, if he wants to make any comment.
No, thank you very much for inviting me. I've been listening with the intent. No, thank you very much.
Thank you, Dr. Badr. Thank you, Jeff. I think we'll be in contact again soon, hopefully. Thank you.
All right. Take care, everyone.